one and all. I'm Dr. Reena Singh. Today I'm going to talk about refractive rehabilitation of keratoconus with cataract with the help of monofocal IOL and RGP contact lenses. So coming to the short introduction, before any surgery in keratoconus, the stage and stability of keratoconus should be assessed. Surgical intervention may cause progression as it has already been studied. There are multiple sources of error. So the precise determination of IOL power is very imperative in keratoconus cases, and to improve the refractive outcome, the IOLs can be combined with various other procedures. Why toric IOLs are unpredictable and challenging in keratoconus cases? There are various biometric challenges that we can face in keratoconus cases that include refractive index error, because keratoconus has altered ratio of anterior and posterior corneal curvature. So standard refractive index of 1.3375 is erroneous in these cases. Instrument error can happen because of pupillary offset that is there in the keratoconus, and as the radius of curvature reduces, effect of K error increases. There is very difficult formula error can happen in these cases because of inaccurate ELP estimation due to steep cornea, higher axial length and deep anterior chamber depth. There is also irregular tear film, so make it more difficult to identify the reliable and repeatable K values in these cases. Why RGP contact lenses in these difficult cases? Coming how RGP contact lenses work. So these lenses acts as a refractive rehabilitation. As we all know, refractive error and aberration in keratoconus is not always fixed or regular. It can be mixed, irregular or high in quantity. RGP has advantage over IOLs that it acts as a pseudo-regular cornea by acting together with tear film lens and compensate for irregularity of the corneal surface, as you can see here in the schematic diagram. Available in multiple options and design, and wide range of corneal irregularity can be covered with these. These are various examples of RGP contact lenses options available for extreme cases of toric changes in keratoconus cases. Coming to the other benefits of RGP contact lenses, these modern RGP lenses are very comfortable, easy to fit, and extremely irregular corneas due to possible design modification that help them to stay over the eye even during sports and other activities, allow oxygen to pass directly through contact lens, so almost independent of blink oxygen supply as we need in other contact lenses, retain shape on blink, thus provide sharper vision. Large coverage and choices are available in newer modifications of RGP lenses. Durability and deposit resistance as it is more there in soft contact lenses, extremely durable with little care. So one RGP can last years and they can be less expensive in long run. Only downside is it may require adaptation in initial period. Why not toric IOL in challenging keratoconus cases? So for any toric IOL calculation, we need prerequisite like detection of abnormal corneal shape, evaluation of corneal cylinder, evaluation of irregular astigmatism, and evaluation of corneal spherical aberration, which is very difficult in keratoconus cases, as there is very high chances of irregular astigmatism in keratoconus cases. Regular astigmatism can also often be present, but determining the ideal toricity is ambiguous due to vertex tips or pupillary offset. Stability of astigmatism is also a problem in these cases. Keratoconus measurement conventional method are not reliable because of change of refractive index, and posterior corneal astigmatism is neglected in these cases. So newer modalities can give a better analysis of refractive index and anterior posterior cornea, but they are not more realistic. But they are realistic in a sense of calculating the keratometric 2 value, but they are not very useful for us because it will deviate from normal sagittal K values, which is used in conventional formulas. So is TCRP or ERP is an answer? Not exactly in advanced keratoconus cases. These are not actually the answer of difficulties. Pupillary offset is another difficulty in biometric calculation, and it is both there in X and Y axis. Mean arithmetic value of TCRP increases as the pupillary vertex distance increases. Leave aside the axis change, even the magnitude changes itself will cause huge surprise in IOL power, especially if IOL is toric. So axial length measurement is also a challenge in these cases. So IR formula also has limitation in keratoconus cases because most of the formula has been developed for normal eyes, and there are various biometric changes are there in keratoconus. Still there is no clear consensus or agreement to which IOL formula to be used, and larger studies are required, especially for toric IOLs. Post-operative concerns are also there. Predictive error are increasing as the stage and toricity of keratoconus increases. This has already been proved in various studies. Post-operative concern also include the disease progression, and IOL rotational stability is also very less as the keratoconus advances. So coming to the conclusion, I'm not totally denying toric IOL, but toric IOL can be an option in only very early stage 1 or mild cases, but concern that cannot be compromised on the name of one-time surgical solution is biometric challenges and questionable stability of both disease and IOL rotational stability. RGP lenses here has advantage. We can target the hyperopia in final IOL power, and patient can be put on RGP contact lens that compensate for corneal irregularity with tear lens, can be readjusted for IOL surprises or progression of ectasia, has wide range and design modification for irregular advanced cases of keratoconus, time-tested, excellent reversible solution even in post-operative progression cases. So it's a solution with satisfaction. So coming to the end, toric IOL should not be considered in patient with very progressive disease or already progression is going on, patient with difficult refraction, or in whom there is high difference between pre-operative RGP lens corrected visual acuity and spectacle corrected visual acuity. So my conclusion is RGP contact lenses in advanced keratoconus and high toricity cases.